Hello and welcome to the MedVR Talk Series. My name is Stephen Patterson. I'm the Executive Director of MedVR. The talks have a common theme, which is the journey of the medical XR innovator. This is the 48th talk that we've hosted. It was one from one of our live streams. All the talks are recorded and they're available on our website and very useful for educational purposes. MedVR is a nonprofit that educates and precipitates research in the medical XR field. We have 7,500 interdisciplinary people around the globe who follow MedVR. Let me give you a glimpse into the next talk that we have planned, so you can put it into your calendar. It's a related talk. There we go. We have Dr. Walter Jean talking about his 100 cranial procedures that he has done with VR for surgical planning and AR for guidance. It should be a very interesting talk. The moderator, Jeffrey Jacobson, is the immersive lead at Boston Children's Hospital with 3 decades of immersive experience and is in the position of supporting doctors like Walter Jean. You can find it on our website, but I'll also put a link into the chat. So speaking of the chat, you'll notice down at the bottom that there's a Q&A chat and a regular chat. The regular chat button is for you to for all of us to communicate. If you have a question, put it in the Q&A chat so that we see it and the question can be asked. I'm pleased to introduce our moderator, Dr. Susan Persky, Associate Investigator, Head of Health Communications and Behavior Unit, and directs the Immersive Simulation Program within the Social and Behavioral Research Branch of the National Human Genome Research Institute, National Institutes of Health. I asked Susan because she has a global perspective and because she has a critical eye for evaluating medical XR for the quality of the study design, reduction of bias, inclusiveness of training content, therapeutic or diagnostic solutions. So on that, I will turn things over to Susan, and I look forward to this talk.
Great. Thank you so much, Steve. And thank you for inviting me to be here today. This is a really important area of practice and research to highlight, using extended reality really to its greatest potential in expanding surgical training globally. I think it's particularly important because this is something, we often talk about XR as a route to reducing, global health disparities, but we often talk about it for the future. And I think it's really gratifying to be able to see a case where this technology is being used to do exactly that today, right now. So we're going to take a little bit of a different format than you might be used to. First, we'll start with a lecture by Professor Dhanda, and then we'll be joined by our 2 other colleagues on the panel, who I will introduce a little bit later so that it's sort of fresh in your mind. And then I will be watching for your questions and consolidating and curating those. So I will start by introducing Dr. Dhanda, who is an oral and maxillofacial surgeon at Queen Victoria Hospital in the UK, also an honorary professor of surgery at Brighton and Sussex medical schools, as well as, this is very cool, visiting professor of extended reality in medicine and surgery, which I've never heard of before, at Kingston Business School at University of London. Also founder and director of VR IMS or XR IMS, which I'm sure he'll talk about today, whose mission is to develop training resources for low and middle income countries using XR and to conduct scientific assessment as well. So I will go ahead and hand it over for the lecture.
Thank you, Susan, for Well, first of all, for the invitation to give this presentation, but also for the very kind words and warm welcome received. And as you said, I'll let you introduce my colleagues from India, Anurag and Tim, after my lecture. I'll try to keep the lecture quite short. There's quite a lot of slides, but I'm more interested in hearing from Dr. Tim and Dr. Anurag, really, because I think they've got a really important, significant contribution to make. So I'll take the share screen and I'll bring up my presentation. And we'll play that. So have you got that on your screen? Get rid of those. Brilliant. Okay, so we're going to talk about XR surgical training. And I'm going to talk about a little bit of scientific evaluation. We're going to focus on the paper that was highlighted, and then global health applications as well. And I've got a short little video. I think that gives a bit of a context as to how we've ended up with an image like this. You know, I'd love to have Meta, HTC, any of the big players, Pico, actually kind of support these projects, because I think it's a really powerful image to share with the world. And I'm convinced, as are more and more people, that this technology will have a profound place in global health and bringing some equality to surgical training. So I've got a short little video for you as an introduction.
Over the past 2 decades, global health has focused on individual diseases. Surgical care has been afforded low priority in the world's poorest regions, leaving 5 billion people without access to safe, affordable surgical and anesthesia care. Patients requiring surgical treatment will face multiple hurdles: delay in seeking care, delay in reaching care, delay in receiving care. Reaching the hospital does not guarantee treatment, as many lack the proper infrastructure to provide emergency surgical care. As a result, many easily treatable conditions become diseases with high fatality rates. As many as 90% of maternal deaths could be averted by timely intervention. For those who successfully obtain treatment, 1/4 will experience financial catastrophe as a result of receiving surgical care. To save lives and prevent disability, an additional 143 million surgical procedures are required annually in developing countries. Today's surgical workforce would need to double in 15 years to reach our target of 80% coverage of timely access to essential services by 2030. The total costs required to reach these targets are significant, at approximately $350 billion by 2030. However, the costs of failure are even greater. The lost output will cost developing countries an estimated $12.3 trillion. Investing in surgical services is affordable, saves lives, and promotes economic growth, making surgery an indivisible, indispensable part of healthcare.
So that's a really important landmark piece of work that came out from the Lancet Commission. And what I'm going to show you today, and I'll apologize to some of you who aren't comfortable watching surgical videos, there's some human cadaveric tissue as well. So of course, we're very careful with how we present these sorts of images, but they're quite an important part of the content and some of the material that we've created. And of course, the do's and don'ts of having these kinds of images in social media certainly is not acceptable. So a very short video on the introduction from a human tissue perspective as well by one of my colleagues who's the head of anatomy for VRIMS.
Welcome. My name is Dr. Aidan Giant, and I'm the head of anatomy for virtual reality in medicine and surgery. Before you start, we need to tell you about a few things. Irrespective of where in the world this session is being delivered, we will follow the regulations laid out by the Human Tissue Authority based in the UK for all cadaver-related work. We are also bound by our individual institutions' regulations. Therefore, we must abide by their rules. The 4 guiding principles of the Human Tissue Authority are consent, dignity, quality, and honesty and openness. Human body donors are making the ultimate and selfless gift by contributing to education and research by offering their own bodies. Therefore, any material that uses a donor's body must be treated respectfully and with dignity. In this session, you may be provided with training material or links to access the training material. The material may contain images and videos of cadavers. You should not share the links or the material with anyone or on any platform. You should not view any material containing human cadavers in any public place. You should not breach donor confidentiality or compromise the dignity of the deceased. You should not take any screenshots or photographs, and you should not use any screen recording or recording device to capture these sessions. Finally, you should not post or discuss sensitive material relating to this content on social media.
Okay, so now that we've got the housekeeping out of the way, and that's quite important for us. I'm, as Susan said, a maxillofacial head and neck surgeon. This is my surgical practice. I'm a free tissue transfer specialist using reconstruction with free flaps for head and neck. Now, you know, one of the things that I do is virtually plan these operations in anticipation of using customized, personalized approaches to reconstruction. But I have to articulate these kinds of instructions to somebody on the end of another screen. Imagine in VR being able to simply be able to pick up a patient-specific fibula and a patient-specific mandible and being able to manipulate those to be able to plan surgery. I think that's the future and one of our projects that we have at the moment. And VRIMS is an academic group. It's you know, we're trying to understand this technology, evaluate it qualitatively, quantitatively, using a combination of techniques, sensors in headsets, eye tracking, and I'll showcase some of those publications, as well as motion capture. But the paper for focus is a qualitative evaluation of one of the global health projects that we did. And so, of course, as Susan said, we publish a lot of our work. Our research group is very active in publishing, and I'm the UK's first professor of XR. But what I love about this industry and this world of XR is that it knows no boundaries. It's inclusive. It allows everybody to participate. In fact, the session on the picture on the left is Tomorrow's Surgeons was about women in surgery, was about you know, the global health perspectives. And I've been a fortunate recipient of several big grants to help me to pursue this work. And, you know, those grants, we're active, you know, there's really good understanding of the cognitive perspectives of how XR kind of can offload, and you can use acquisition of new skills quite quickly. We've submitted with co-applicants of Dr. Honorary and Dr. Tim, a surgical education program for LMICs. More recently, enhancing remote learning using AI for adaptive approaches in XR with spatial computing. We've got a post-traumatic hand rehabilitation clinical trial that we're working up at the moment, and a skin cancer detection and augmented reality app as well, amongst our grants. But this slide here kind of summarizes the approach, single step up now to the kind of the true world of XR and the computer engineers. You know, sixth off is VR, not 360 video. That's a camera with a lens at the front and the back. But the entry point for global health is 360 video, because you put something like that on an African surgeon's head where they can see themselves projecting a few minutes early in a live stream. It's just something they've never come across. And that immersive experience has its limitations, and we can adapt that into something called a virtual studio overlay, and then eventually make that an interactive experience, which is not a million miles off 6 degrees of freedom, in which you can physically move around through space and pick up objects. So each one of those doors has opened a door of increasing complexity, and we evaluate it, and then we go on to publish. So cadaveric dissection is where we've concentrated a lot of our work. And with cadaveric dissection, what I've done is I kind of, the reason why it's attractive to look at cadaveric dissection is because it allows us to progress through surgery very quickly. But of course, we're not inconvenienced by the limitations of long operations. My operations last 8 to 10 hours long. Nobody can sit through an 8 to 10 hour operation, but they can sit through me demonstrating how to raise a thigh flap in 20 minutes. And so it lends itself well. We're not inconvenienced by blood. You'd be surprised to hear that most surgeons don't like the sight of blood. We can progress quickly without issues of hemostasis, and it's more predictable. So this is some of the early feasibility work I did. Now, the problem with the 360 camera is it can't zoom in close to see small vessels, which is what I operate with. This is a fibula flap that I raised to reconstruct a jaw, so we can see the quality of the image is good enough for 4K, wrapped around your head, certainly, but it's still limited by the fact that it's a single point fixation. So how do we get around that issue? We start to use multiple camera overlays. So if you imagine your 360 camera is here, in a theatre space or in an anatomy lab. There's the student's 360 perspective, but nobody in theatres stands in one place. We are all constantly moving, looking around for the best view, whether you're an intern, a student, or a surgeon. And so that's the problem with a single 360 camera. Well, what you can do is project a lens from above, and you can overlay that in that 360 space. You can project a lens, an image of a zoom camera right in to see those small vessels and overlay that. So the student simply turns their head to those multiple views. You can put laptop presentations in there, and you can put Zoom meetings as well. So when I decided to run the first course as a consequence of COVID, I was running a lot of cadaveric courses. I needed to think about a new way of teaching because, of course, we had social distancing and proximity wasn't allowed. And so the first course we ran in 2020 sent out these headsets, and we ran a live stream with great success. After this first course, subsequent courses, we still used low-cost headsets. These allow you to adjust interpupillary distance and focal depth, but the key part was that the mobile phone was the VR device. So what you get, if you imagine you watch on your mobile phone, is a clamshell thoracotomy by a helicopter emergency team, but all these different perspectives. So you feel immersed in that training experience. It's a quick surgical maneuver and demonstration, but with these multiple views. And you can see here the anterior cardiac ligaments in the chest wall, which you would never see in a single camera perspective. So what we ended up doing when we published this is that we were able to live stream those courses to anywhere in the world. And all you needed was a low-cost mobile phone with a low-cost headset, 3G network or 4G network, and suddenly we had something that was very scalable and accessible and affordable. What we did after the first week was we banked all the content, and after 6 weeks of courses, we had a vast library of more than 300 videos of every surgical video. Now, to create a 6-stop in any one of these procedures is tens of thousands of pounds and takes months to do. So this is what we've got. This is me demonstrating a thigh flap with the multiple cameras. Imagine this wrapped around your head. This is an orthopedic surgeon, upper limb, urology into the retroperitoneum. We can put cameras into the retroperitoneum. These multiple camera perspectives, you just simply turn your head whichever view you want. ENT procedures with endoscopic views, ophthalmology, small anatomical sites to demonstrate these procedures. Neurosurgery, two senior surgeons talking about how they've adapted their techniques with the multiple camera perspective. Back to trauma, a big part of global health. Complex injury, limb injuries with multiple specialties talking about their perspectives. Into the chest with cardiac surgery. Again, you can imagine these multiple images. Orthopedics, very important, an overlay of a PowerPoint presentation and posterior approaches to the elbow. Obstetrics and gynae, 20% of perioperative mortality is obs and gynae. So we've got a wonderful library. And of course, a Blake's knife in skin graft. Never used it in my practice. But of course, in Africa, they don't have power instruments in rural Africa. So we have to learn to use instruments that are relevant to pathology that is relevant in these remote parts. And so the global perspective and the focus on Africa was as a consequence of this obvious statement. Look at the cartogram, and the number of doctors per population in Africa is a fraction of the rest of the world. In fact, I'm going to Burundi next week, 0.18 doctor surgeon per 100,000 population. That's my thumb, essentially, in terms of the amount of a surgeon for that population. We've published some of the early work as feasibility, particularly with bellwether procedures, and managed to stream to 40 countries and several thousands of participants. And so in the end, in those 6 one-week courses, we streamed to more than 100 countries and 6,000 participants. And in we're not going to have time to show you their perspectives, the surgeons and the anaesthetists, and zip through that. But what we did do in these courses is we ran a 4-day rather, cadaveric course. And again, I'm going to be quite kind of clear. I'm not saying for 1 minute that this technology will replace the apprenticeship of surgery, the haptics of tissue handling. That has to be learned through surgery. But actually what it will do is it gives you the 3-dimensional, the 360 perspective of surgery. And, you know, those interns and those medical students, how many of them are standing in theatres and actually doing anything with their hands? Very few. They don't need haptics. What they need is to be able to see and listen with surgeons describing. And what these videos show you, they give you the best seat in the house. So we ran this 4-day course, very much influenced by local pathology, local needs, local resources, including obs and gynae. So it was informed and we, in fact, supported faculty, local faculty as well. And that's the screenshot you saw at the beginning of the Ugandan surgeons. What I love about this image is that the surgeons in the foreground are having this hands-on experience with cadavers live streamed to their colleagues in Kampala in the background. When we ran that feasibility study. And of course, we came across some wonderful talent in Africa as well. And so that was the publication where we evaluated that 360 visualization with the multiple camera overlays. And, you know, it was pretty convincing. I think everybody said unanimously that the experience added something to their educational requirements. And so the content was focused on those procedures defined by the WHO Health Organization Global Burden of Disease. We had a combination of hands-on experience, live streaming, remote streaming, and in the end, it went to 556 candidates in 25 countries demonstrated. And so pretty convincing, very easy, relatively easy in terms of setting up the equipment, in the attractiveness of VR, again, very high scores on that. So in conclusion, that paper, the outcomes of the first VR global health project, it demonstrated, you know, as well as collaboration, that VR has an important role and can be used to upscale postgraduate surgical education as well as undergraduate education in countries, in low to middle income countries. And so that was the survey of whether the participants thought it could be useful and adopted into curriculum. So that's where we focus now with VRIMS. We're setting up 10 African hubs. The first 5 have been set up. We will have process in place, and hopefully that will be a catalyst for investment of more equipment, as well as this huge library that we're taking out with us. The next trips we have are Burundi. We've got to Cape Town for the Innovations in Global Surgery Conference, where we get to showcase this with the workshops, and then go to Malawi afterwards. And so there's, of course, frugal kind of considerations as to how we do that. When we did that UK course, very expensive to bring African surgeons from rural parts of Africa. So most hadn't even left the country, didn't even have passports. When we started to do the visits out to Kenya, and this was the experience with the Sudanese surgeons, again, we're a little bit restricted in time to give you their perspective. We've got a Sudanese surgeon coming to join us in Burundi next week. This is the workshop in South Uganda. Anesthetists, again, surgeons can't work without anesthetists. The perioperative team is important. You can see an overlay of a fiber optic intubation. We went to Cameroon and we created some regional anesthetic workshops, as well as Uganda. We package that up and we give it back to our colleagues in Africa. We went to India with Dr. Honorary and filmed some obs and gynae simulation work. And again, that's all there in the library. This is the first ever C-section with a multiple camera overlay. And without fail, every single medical student that participated said, this is the best seat in the house. I normally don't get this surgical experience. I'm normally disengaged in that theatre environment because I'm not part of that process. Residents are huddled around. I can see very little and nobody's articulating their instructions as well. And so again, we published that. We're going to be creating some 6th off in these critical procedures like gaseous laparoscopy and Wallant. And this is our Cameroon trip. And Dr. Tim will talk about that earlier this year, where we ran that regional anaesthetic workshop. This is our Zambian trip, where we ran that workshop in Zambia. And so this is the trip coming up in the next couple of weeks. I'm going to finish off with the last few slides and talk about the UK perspective. You know, we appreciate the importance and significance of 6th off. And so we've created a fire safety simulation for mandatory training for 1.3 million NHS workers. They all have to have fire safety training. And we've created this app, creating a digital twin of a ward in our hospital using a combination of 360 video and, of course, 6th off, where we can then start to assess how people can manipulate through opening doors, selecting extinguishers. And we're going to evaluate that, of course, scientifically, and show that there's a benefit in this multi-user interaction. We've got an augmented reality app that can overlay critical anatomy of the face and help surgeons make decisions. You'll see me playing about with that here, where it can overlay the subunits. As a facial surgeon, I manage each subunit very differently. Imagine attaching a dermoscope and being able to have AI approaches in diagnosis, but then also use the augmented reality app to overlay critical structures of the face, like the facial nerve, Patangi's line, which is the frontal branch of the zygomatic of the facial nerve as it crosses over the cheekbone, a critical zone for us in terms of risk of weakness of the forehead. And there's the facial nerve being demonstrated. So that's a clinical trial in the making, both in terms of surgeon usability and also diagnostics as well. And we're looking at eye tracking in pathology. We've got an advanced trauma life support chest drain insertion with hand gesture control, and we're using the same technology for a clinical trial in post-traumatic hand rehabilitation. Again, imagine scanning your hand, your contralateral non-injured hand, and using that for an individualized approach in the range of movements, and then a tailored AI approach for adaptive rehabilitation. That's a clinical trial that we're working up at the moment. I think Sixth Off is going to change imminently with generative AI. We've got a partnership with Arama VR where we're going to have surgeons building in Sixth Off in this platform Mages, in which you simply walk into it's like a supermarket. You pick up all these objects with physical interactions and properties already predetermined using Gen AI. And so in the last couple of slides, we've got some virtual human projects with Verti. What I've described so far with the 360 video, Apple decided to drop stereoscopic view on YouTube on their devices. So we had to create our own app to stream, because in Africa, not a significant issue. Most surgeons have Android devices, but certainly an issue in the UK where most surgeons have iOS devices. And more recently, we've been trialing this concept of synchronized training approaches where we can connect all the devices together, and then we can run a workshop where we can watch these videos. And so I can run a workshop in obs and gynae, which is what we're going to do in Africa next week. We're going to run synchronized VR training sessions in O&G, trauma, this huge library in orthopedics, plastics, rehabilitation, and that's just some snapshots of the workshops. We've got nearly 70% of the medical students societies in the medical schools in the UK signed up to our programs now as we roll out these libraries. And then interactivity, we can add in interactivity by adding in interactive hotspots that can be triggered by head movement. That's quite important for us because it allows us to change the narrative of the videos depending on the level of training. So this is a question that I wouldn't expect a medical student to know to assess blood flow through the forearm, but what I would expect them to know is the anatomy of the forearm, and I can overlay those sorts of critical anatomy pictures with diagrams, so change those narrative of those videos accordingly, and you can access those in more sophisticated headsets. So in the last couple of slides, I'm convinced this is how we're going to deliver the workforce plan in the UK. There's a big push to double the number of medical students, but nobody's talking about doubling the number of surgeons to train them, physicians to train them, GPs to train them. How are we going to do it? We're going to do it through XR. And so that's what we're doing in a course, and we're live streaming in September, multiple specialties. And I'm going to finish off with just a bit of the scientific evaluation stuff. We've looked at gaze. There's some subtle and very important differences when we've looked at a basic life support app. We've looked at motion capture, and we've shown differences in body posture, particularly without haptics. That's quite important. And I'm going to run out of time to show you some of those results, but they're all published in the literature. And I guess I'll finish in my 25 minutes that I've given myself to just welcome you all to the UK's first dedicated XR conference that we'll be hosting in October for industry. Academia is the focus for me, and as well as looking at healthcare applications. So I'll stop at that, Susan, and whirlwind tour through RIMS and our work in global health, and we can introduce our colleagues.
Okay, wonderful. I am so impressed how quickly you went through that. I thought there was no way, but bravo.
Thank you.
So what I'm pleased to do right now is first invite you to go ahead and post any questions you might have in the Q&A. We can start accumulating those questions as I introduce and sort of start with a few questions of my own. So we will now sort of open this up to a panel. I'd like to invite our two other colleagues, especially since it's not really work hours where they are. So thank you so much for joining us. I want to hear about their perspectives in these efforts. So first, we have Dr. Anurag Mishra, who's a surgeon and professor of surgery at Maulana Azad Medical College in Delhi, fellow of the American College of Surgeons and Association of Surgeons of India, a founder of Innovations in Global Surgery, a multidisciplinary group promoting safe, affordable access to surgery. Also, Dr. Tim Tanchu, who is a general surgeon for the Cameroon Ministry of Public Health, a professor of surgery, University of Bamenda in Cameroon, and global surgery lead with a humanitarian NGO delivering surgical care and also coordinating surgical simulation. So I'm going to start with the first question to this panel. I'd really like to give Anurag and Tim an opportunity to talk about their experiences with BRIMS and sort of this type of effort in general, and sort of talking about your role and your work in expanding surgical training on this global scale, and sort of the benefits, maybe the challenges, and what you've seen from your perspective. So I invite either of you to go ahead and jump in to start, and then we'll, we can pass it along.
Okay, I'll go ahead, I think, first. Thank you, Susan. Jack, as always, a wonderful presentation. And I think you asked the question why I jumped into this, and I think if you listen to Jack's presentation, it's very difficult not to be moved by it. And I think that was the reason. So when first I saw the possibility of this, we were using VR in India for gaming and for other things. But suddenly, as we start realizing that this can be used for surgical training, and this comes at a time when we are struggling with the same questions. I think if with all the resources, if UK is struggling to find answers to train so many doctors, you can imagine what a low middle income country would be facing. So the need of trainers training and quality training is huge. We can have trainers, we can have people going across the country and train them, but to have a standardized training all across the country, I think that is very difficult. So we need something which can be delivered across the country by using something which is already there. And I think that's the power of mobile phones. I think one commodity, I think that's why innovation is helping us, because almost everyone has a mobile phone. And if you add just a low cost VR, which is like 500 rupees, which is like a very cheap, it's affordable, and then you deliver a quality content. So at least something. The hope is there that yes, we can do something. So that is the power of VR, and as we see. And initially, yes, there were a lot of hesitations that whether it is good or not good. It might lead to some headaches after some time, because the thought of wearing the VR set for very long. But then we started trying it with students, with surgeons who are practicing, and we got very encouraging results. So, and I think I would say we are still in process of learning to implement it, but I think at least I'm convinced that this is a thing to go for and scale it up. And so that's my first remark.
Oh, Tim, we're not hearing you if you're.
No, I'm not hearing you, I'm afraid, Tim. Try again.
Of course, it was working earlier.
Yeah, of course.
No, not yet.
No, sorry, still not hearing you, I'm afraid. You had another screen up. Whilst Tim is struggling to talk, I'll just give you a bit of a background to the invitation with Tim and Anurag. In fact, we've hosted a couple of workshops in MAMC and Ludhiana, and MAMC and Ludhiana are going to be one or two pilots in India that we're going to be setting up. And Dr. Tim kindly invited us to Askaveen, which is a wonderful centre just outside of Yaoundé in Cameroon, to run a workshop. And it was a brilliant experience to see medical students, nurses, healthcare professionals, physicians, associates, surgeons, all collectively coming together for a combination of simulation training. We ran that regional anesthetic workshop as well. You know, these individuals from Ascavim give up their weekends to be able to go out into Cameroon and dedicate their own personal time and resources to improve the health of their nation. And that's an inspiration, certainly for me, to see. And the wonderful taste of their local food, see their wonderful countries, and it's a wonderful warm feeling that we get when we go out to these centres. So Cameroon is one of the 5 centres that we put into a big grant bid, and we will be setting up again a pilot with the low-cost mobile phones. And if I'm absolutely honest with you, Susan, it isn't the hardware, it isn't the software, it's the content. That's the key. You have a massive library, and then you can figure out a way of manipulating the software with synchronized VR, Verti interactivity. You can figure out the headsets with the low-cost Quest 2s or 3s, or going on to, you know, the Apple Pros, unlikely. But it is the content that's the key here, and I think that's what we want to share as an entry point for XR and use it where I think it have made massive impact. Are you talking yet, Tim? Have we got you working? No, you're on silent. So we're all going off.
Oh,
You may need to disconnect the audio and the registry, whatever you're feeling, and then
Do you want
reconnect.
to sign out, Tim? Sign out, Tim, and sign back in and see if that helps.
okay.
Sign out and sign back in and see if that helps. Right. Any questions?
Right. So there are several questions that have come up, and why don't we, you know, I want to ask about sort of the relationships and all of that. So we'll wait until Tim comes back for that. But I think we can take more of the nuts and bolts questions perhaps. So there are, you know, I think one of the questions that's certainly coming up is use of 360 and use of XR, and sort of deciding, you know, what kind of approach is best for what kind of content. There's a question about, you know, a 360 approach not being interactive. So sort of what is the role in overall training of doing, you know, more of these sort of observational, you know, approaches.
Yeah. So 360 video on its own, is a wonderful resource for several reasons. One, you can create content very quickly, and if you've got a little mini kind of movie set where it's all choreographed, okay, it takes a lot of thinking. But for surgery, you just can't use it because you're not in a single, as I've said, in theatres, you're not standing still, you're constantly moving around. So the overlay allows us to create big amount of content. And you're right, it's not interactive until you start to add in hotspots. Now you can have a sense of, but not quite sixth off, you have a sense of interactivity where you can add in hotspots. Verti allows you to actually create assessment tools, so you can use it in formative and summative assessments. But what's great about interactivity with a passive video is that you can change the narrative. So the narrative can be changed. This project where we have just submitted a grant for an AI for adaptive learning will actually look at the triggers of the hotspots and then change subsequent questions in that 360 video so that that interactivity is tailored to the individual as they progress through simulations. So 360 video can be interactive, and actually using AI to make it adaptively interactive is a really exciting opportunity. To you, Anurag. Tim, can we hear you?
Can you get me now?
Yes.
Yes.
That's wonderful. Yeah. So Susan, I wanted to say that, like, just to set the context, like as Jack earlier said, Cameroon has been trying to upscale the number of surgeons we train, and by like opening more positions in undergraduate positions, and this has come along with multiple challenges, like trying to increase the number of students that are being trained, but you can't increase the number of teachers as quickly. So you have now like the number of mentors mentoring a single student, the number of students is like relatively very big. Like when I was a medical student, we probably had like a surgeon, you probably for any rotation will have one like 4 or 5 students for a single surgeon. So now in my unit I have 30. So 30 students, probably like the experience becomes like very, very crazy for them, like they go through all their rotations without having any real life experience. And this has repercussions when they become like practitioners working in the periphery. Like in Cameroon, we still have a lot of task shifting and task sharing. So most of the essential surgical care is provided by non-surgical providers in the regions. And with ASCOVIM, the NGO Jack introduced previously, like we go to villages and we go to rural areas to provide surgical care. Mostly, we do a lot of hernia surgeries in the villages and take more complex procedures to the big hospitals. But what we found out was most of the providers had real challenges like learning and improving on what they are doing. And we had this recurrent feedback on, I had this case yesterday and I couldn't know to see what to do. Sometimes they have to call you up on the phone. And so we, at ASCOVIM, we thought, oh, starting a simulation program and getting these medical students to, doctors and medical students to come and have a more hands-on experience with more experienced surgeons, teaching them more essential things like C-sections, laparotomies, and open fracture management was a great idea. And coincidentally, this kind of aligned with when we got to meet Jack through the Ugandan project. There were some Cameroonians who participated in the project in Uganda, the anesthesists, and they came back and they gave us feedback. And for us, it was not an opportunity not to miss. And we tried to reach out to Jack, and luckily for us, he was available and was willing to come with all these equipment. So the workshop we had in January was our first experience in virtual reality. Like we look at videos, like every surgeon, you try to go to videos on YouTube or just other surgical platforms, but nobody had previous experience on VR. So we had a workshop in Yaoundé in January where what was fantastic, we actually integrated VR like simulation on dummies at the same time, like animal dissection in the same workshop. So students went through the different experiences. So we had a unique opportunity for them to compare what they learn, like moving from one thing to another, and going through the VR and coming to do simulation on a dummy and moving to more live subjects. They kind of felt more comfortable. And you have this more immersive experience for them when they are going through the training. And the extended reality headsets, I had the opportunity of using them. For me, I think for the undergrad students in terms of training for anatomy, it's like revolutionary. Why? Because I think like most of us are medical students, and anatomy has been one of the challenging subjects for you to pick up. There are lots of things you will have to gain and you have to learn, and lots of new words and a lot of like understanding just what organ is situated. But if you have the XR headset, you actually can move all these organs side by side and just build them more back like a puzzle. And building this puzzle for you, you're like, there's more interaction. Like you take 30 minutes to go through a whole book of anatomy on the limb, for example, going all through the muscle, origin, termination, all the nerves, all the vessels. So for me, it's something that, like, if it's needed in the high-income countries, I think in Africa, in low-income countries, it's like more needed. We need this to scale up. We need to get to the numbers, first of all, of our number of surgeries, but we also need to catch up on all the complexity of kind of surgery we can offer to our patients. And even for me, a consultant general surgeon, I do a lot of colorectal and digestive oncology. I have a lot of challenges in me progressing. Like it's not like where we have organized colleges where we have all this training going on. So you get to the point where you feel you kind of stagnate and there's nothing. How do you get to improve? How do you get to go through this case that I have these recurrent complications? And I think it's due to how much skill I have to do it. How do I go about it? And I think VR and everything that it comes with will just help all these different colors of trainings and surgical providers to improve and ameliorate what we have to offer. And for me, with it, I think the future is more we see more optimism for most of us and most of the students who participate in our workshop.
Wonderful. Anurag, did you want to comment on the previous question?
Yeah. Yes. So okay. I think the way I see virtual reality is it is not just a 360 video or immersive or a metaverse. I think it is a set of resources, a set of technology-driven resource. And why it is important to talk about it is, especially with my experience in India and some countries, there's certain group of people, educators, trainers, who would very strongly believe in the traditional method of training. So I think there's a strong need of breaking them towards using technology for a scaled up training. And if you do it with 360, you do it with VR or whatever, and then suddenly they are pulled towards a huge gamut of resources which are available. And for different things will work. So what Tim was mentioning, the telementoring using virtual reality is again another very useful tool where even a senior surgeon might take help from another experienced trainer in that area across the country, across continents. And so I think it opens doors to so many possibilities. So I think that is the beauty of it. And I don't think we have still seen all of the potentials of this technology. I think we're yet to see it.
Okay.
So right now across the globe, I think the need is to I would use the word to convert them into the religion of VR and then see the possibilities.
Wonderful. So yeah, I think it's a really important point that this is part of a larger whole. And there's more roles that XR could serve, and certainly there's roles that XR will never serve. I'm really curious about the relationships sort of between the organizations and the sites, and how that works, how you sort of work together in thinking about what cases will be covered, what are needs in particular sites, any tailoring that needs to be done as these sessions and these programs are sort of put together.
Hi, Susan. Sorry, I missed that.
Oh, sure.
Do you want to just...
My question is really about how you work together between maybe the UK site and sites in other countries in thinking about what trainings will be held, what are the needs of different sites around the world, and sort of how trainings are put together and the content.
Yeah, sure. So I think you've got to think about the population and their needs, the surgeons, the clinicians and their needs. The model certainly for somewhere like India, for example, where you have a lot of you have the big cities, a lot of wealth in these big cities, but there's still a real kind of need for training in a rural setting, for example, in some of the remote parts of India. So how do you justify going in to invest into countries like India, which has the biggest population in the world, huge local talent pool as well in the tech industry? I think the way that we're going to do that with VRIMS and the vision that I have is that we go into the big teaching centers, we generate pilots, and we try to formulate some form of a business model that can then create a sustainable approach to training for the rural and remote setting. Africa is a little bit easier of a convincing kind of program. When we go, we're off to Burundi next week, and I'm inviting a Sudanese surgeon to come and join us in Burundi. The population and the problems in Burundi will be somewhat different to somewhere like Kenya, Cameroon. And so you've just got to be mindful of what the local requirements are. Burundi has the smallest number of surgeons per population of 13 million for the whole of East Africa. So there's a real need to want to concentrate efforts in those places in Africa where there's limited resource.
Wonderful. And I don't know if anyone else wants to comment on, sort of the role of different entities and sites in putting together trainings or planning.
So I would just add something. Like, I think what VRIMS is doing and what maybe, let's say, Jack's role is to create a library. And at least to my end, that we have the local sites have the full freedom to customize the program according to the needs there. And it can be different. Let's say in India, if you have two different programs, the objectives might be different. But if you have a good library, and which I think Virenj has been able to create, you can just customize it and do it. You can have a orthopedic focused workshop, and next time you can have an obs and gyne focused workshop. So if you have a library, and I think at least I have found that working with JAG, that freedom is there. That it's not like the JAG will decide or Virenj will decide. The local trainers can decide what content they want to pick up. Yeah, that's what I wanted to add.
Yeah, so I think that's the right approach. Like, I think from my experience with interacting with Dreams and the workshop we run, like, it was rather Dreams trying to fit into what we wanted to offer to our trainees and to the local population. So we were invited to visit all the resources that were available, recorded videos. And what we did was we organized the main session, and we had breakout sessions in urology, in orthopedics, in obs and gyne. So one whole day for obs and gyne, one whole day for urology, one whole day for orthopedics, where we invited the mentors and the coordinators of these different surgical programs, and they like went through all the recorded material and decided on what they thought was most relevant for the trainees at the time when they were doing this training. So there are lots of other things that we feel, okay, progressively you have to start from somewhere and get to that all high tech that we need, but that has to tie in with what is available on the ground and what we are ready to offer, so that we ensure safety. That's why the resources available for us, but we were the ones deciding on what was to be used and what was not to be used for the trainings at the time the workshop was going on.
I mean, I think if I can just finish on coming on that, Susan, I think the vision that I have, and what we haven't done, Anurag and Dr. Tim, so far is I haven't shown you synchronized VR. And one of the limitations that we had in Cameroon, particularly in Ascovine, was the low bandwidth. You only need to connect 3 or 4 mobile phones to one Wi-Fi dongle, and it's slow. So what we've done now with synchronized VR is they are preloaded. The content is preloaded on the devices. Okay, they're a bit more sophisticated than mobile phones, but by having a synchronized approach means that I can run an obs and gyne workshop. I know nothing about obs and gyne. How can I run an obs and gyne workshop in Zambia? It's because each of those videos has a context with a webinar that accompanies it. So it's not just the demonstration. And having the webinar gives you your knowledge acquisition and then the demonstration of that immersive experience. So it means I can go and run a webinar in which I can play Kathy's wonderful video on postpartum hemorrhage, and then hit VR demonstration. Everybody puts their headsets on. I don't need an internet connection, and I can play that 360 video and give a narrative at the front if necessary. And then likewise with uterine inversion, a wonderful lecture by John. And then we go into that demo. Now that's almost filled the whole morning in O&G, and I'm a head and neck surgeon who knows nothing about O&G. So that's what the new approach is, and it's iterative, and we're learning how we manage the technical nuances, the limitations, by creating these XR hubs. You know, most sim centers get a flurry of activity at the beginning of any new tech that arrives. There's a lot of footfall, but then they're quiet. If you go to most sim centers, they're quiet. The way that you start to increase footfall is you build an XR hub into the sim centers, because the content then is always available. It will protect the human tissue resource. You have to watch the video, you have to sign in. It increases footfall into the sim centers as well. And so it draws and attracts people from every healthcare professional rather than a focus on surgeons. That's the vision that I've got for these XR hubs in Africa.
Fantastic. There are several questions in the Q&A about sort of particular plans for the future. So I will ask sort of and I think you just sort of talked about this, but in terms of the catalogs and the cases and such, there are questions about pediatric cases, whether there are plans or needs in that arena. And there are questions, an important question about how to get in touch for more information or getting involved in the project. So I imagine that, you'll want to give that information, and then sort of curating the catalog. And there are questions about, video labeling and sort of, metadata, and sort of, whether there are plans to go back to existing or make changes in the way future content is sort of displayed in the libraries. So I apologize, that's a lot of questions, and I'm happy to repeat, individual ones.
Yeah, sure. I mean, I think I'm happy people can connect to me on LinkedIn. I use LinkedIn quite a bit. The vision going forwards would be to establish the 2 pilots in India, show that there's some method in our madness, and then maybe roll that out to the rest of Indian colleges and build a model that can then generate income to be able to roll that out to the remote and rural settings in India. In Africa, I think the first 5 hubs, I'd like to get 10 XR hubs set up in Africa, and then use those as catalysts for people like Zuckerberg and Meta to see actually where their technology will have massive impact to invest. And it doesn't need big investment. Any one of those images that I've shown you, if Meta had, is a powerful statement of where this technology will go in the future. And so I'm hoping that that catalyst will lead to more investment into those more sophisticated headsets, allow for synchronized training, and bring this resource into without the overcome some of the difficulties of internet connectivity and so forth. So that's kind of the catalyst to build upon, I think, in the future.
Wonderful.
Over to you, Honorary.
Yeah, do either of you have any other comments or thoughts there?
So yes, I think the future I would like to see is, yes, more sophisticated headsets, but at low cost, which LMICs can afford. And like I think headsets are you can see headsets everywhere now, maybe for gaming or for entertainment purposes. But from the focus of this, and I would not be shocked if the governments will start getting interested in these ways and start using it at a mass scale. So that's the thing. And as more and more people get involved in this, I'm sure the full potential of this will be tapped. More minds will start thinking around what more innovations can be done around virtual reality. So that is I think it's like a nuclear reaction kind of thing that will go on.
Did you see the picture of Modi wearing a VR headset last week, Anurag?
Oh yes,
Even your Prime Minister seeing the potential.
I think yes, he and he is one person I think who can just, if he believes in it, he will go all in.
Yeah, so then I think like surgery, the future of surgery in Africa, there are things we think we have to get better, and safety is one of the main concerns that we continuously go over and over, like how safe can we make our procedures? We have poorer outcomes for same procedures with patients that are comparatively with the same risk in high income countries. And I think training is all about repetition, and VR comes with this possibility of us doing the operations 200 times, and with the interactive nature of the headsets and prompts and questions, we have the possibility of evaluating the trainee and giving the possibility of knowing when you can translate this from virtual cadaver dissection to actual human tissue, lifestyle procedure. So it kind of increases the safety element and protects the patient more than we trying to learn with like students who are not all that of skill, and they have to train. So you have to, at one point, we will leave them to go on to procedures where they are not more aptly, but you have the possibility now as a trainer to actually see where the student is and know what safety level and how much supervision you have to give when they go to actual human tissue. So virtual reality gives that possibility. There are multiple challenges, as Jack already said, with internet connectivity, with buying, with people sticking to stereotypes and not wanting to move on like the traditional ways. But I think the context of Africa imposes this technology upon us, and us who are engaged in training will one way or another have to start learning. I think the difficulty usually is also really just understanding what VR is about. I think getting my head around it was not easy myself, so I'm still learning. But I think for the students, it's much more easy. They go around all the video games and 3D headsets, they're already using them. So when you get them connected to the headsets, you are surprised at how much they express themselves and how much they can bring on the table for you and the training. So you start learning from them how to use these headsets. At the same time, you have the possibility to mentor them through training with more specific things on the training.
Yeah. I have one last question. So I've had some engagement with ARVR Africa and other groups who are supporting XR and other content generation within low and middle income countries. And I'm curious about, your outlook on, so since content and context are so important, the possibility of, content generation, within the sites, and sort of what the role of that could be in the, in sharing among sort of the larger whole here.
Yeah, I mean, I'm really excited about the prospect of generative AI to allow clinicians to build in 6DoF. And I don't want to sound like the computer engineers who are very cynical about 360 video. Actually, the fine anatomy is really difficult to recreate from a creative artistic perspective, particularly when there's variation in anatomy. Again, Anurag and Dr. Sim, we've recently just acquired a 3D organon license. And imagine being able to put on a VR headset where you can pick apart the anatomy 3-dimensionally. It's wonderful to be able to manipulate that and understand the operations. Of course, I'm coming at this as a surgeon and trying to explain how surgical maneuvers and principles of dissection through tissue planes and that 3-dimensional side has a real value, I think. So I think the future will be 6DoF. The future will be affordable, accessible, and scalable, with Gen AI allowing for significant increase in the creation of simulations that require manipulation. My only worry is that I think haptics is a long way away, but as I said early on, I don't think you need haptics as an early career surgeon. You just need to acquire knowledge. The haptics won't be replaced anytime soon by anything other than the apprenticeship of surgery in the theatre of theatre. But an operation is something more than just what happens beyond my fingertips. An operation is about the entire environment, how I train my trainees, how I manage a nurse who's not familiar, how I manage a complication or difficult anatomy, and that 3-dimensional or 360 perspective is important, and I think XR can bring that to the table.
Anurag or Tim?
I think nothing from my end at this point.
Yeah.
So, Susan, I think we had this discussion about the challenge we had, like looking at as Jack said about the environment, like the videos are recorded in high income settings where you have like these theater environments that are really high tech and has like just the environment is different from what we're used to experiencing. And I think what I find interesting and motivating for me was this content creation, like using content that was actually created in Africa, in Cameroon, in Uganda, and introducing them on the platform, like doing this regional nerve blocks that actually run in a rural, like in an open air area in Bankomo, that's the outskirts of Yaoundé, and putting this on the platform. So the African or the Cameroonian resident in anesthesia who gets connected, get somebody who speaks with the same accent like him. Right. We're working on dark skin and like just like you, and you feel more integrated and more connected to this kind of training. And the next phase, as we had a discussion with James, was actually teaching the surgeons and surgical teams in Africa, us, and to actually create these videos ourselves. So using our videos in our operating rooms with our challenges, and in on the whole platform of virtual reality, creating different hubs. Like we can have a Brims Cameroon, like a section that can be accessed by Cameroonian trainees and still hosted by the main platform. So you want specific things on specific subjects that are related to your environment, you probably go there and see what is the current standard of care in your setting. And you're not trying just simply to copy what's being done in high-income countries.
Yeah, that's so important. And I want to echo all of the comments that are coming in and all of the statements and the question and answers that are just full of compliments and everyone just being so impressed and just loving this program, wanting to reach out and get involved. So I will just reiterate what Jog said, that he is on LinkedIn. That would be one way to contact. I'm sure MedVR would be happy also to help with that. And so, with that, thank you from me to all the speakers, and I will go ahead and pass it back to Steve.
Wonderful. I want to thank everybody. This was an incredibly engaging session. Usually the chat isn't as active as in this case, with people who want to get involved, both from a technical, academic, medical standpoint. And I'll make sure you get that chat, and if I can help connect people, I would be happy to do that, because this is a phenomenal mission, and your engagement and traction is so strong. And we'll also prioritize this in our search engine optimization, so that more people find it, because it's a great story. Dr. Dhanda, Tenchu, and Mishra, thank you so much for joining us, and for a great presentation and superb content, and staying up very late past your usual workday. Susan, thank you again for moderating. I knew you'd be the perfect person for this, so we'll look forward to the next time when we do this. And thank you, everybody, and to our audience, thank you for joining us. Take care, and we'll see you next time.
Bye-bye.
Bye-bye.
All right. Thank you, Susan. See you.
Thank you all.